Well, good evening and welcome to Humber River Hospital Community Town Hall, and thank you very much for joining us. My name is John Derringer, and we're here with Barbara Collins, President and CEO of Humber River Hospital, and ER Dr. Taslim Nimji, who is also Director of Medical Innovation here at the hospital. Good evening, ladies.
Good evening.
We're glad everyone on the line could join us, and we look forward to speaking with you about healthcare, Humber River Hospital's programs, initiatives, and service. Also, it's an opportunity to gather your feedback and ask your questions. So a few items. One, if you do have a question, please dial *3 on your phone to get into the queue. We'll do our best to answer as many as we can. We'll be hosting some live polls throughout the next hour as well. We are live in Humber River Hospital's incredible command center. For those who may not know, Humber River Hospital's digital transformation began in 2005 with the planning of the hospital's new location, which opened in 2015, making the hospital North America's first fully digital hospital, located at 1235 Wilson Avenue near Keele and the 401. Humber River Hospital launched the first generation of the Command Center, in 2017, providing real-time insight and helping to manage patient flow throughout the hospital. Since the launch, Humber River Hospital has unlocked inpatient capacity equivalent to 35 additional beds, eliminated hallway medicine, and reduced emergency wait times, despite experiencing 8% growth in emergency department volume in the same period. So, once again, *3 if you have a question that you'd like to ask. We would love to hear from you. And we're going to start off with one of the most important and biggest and most pressing questions in healthcare today: emergency department wait times and eliminating hallway medicine. Many have or may know someone who has recently gone into an emergency department or any hospital and has experienced wait times for appointments, tests, and procedures being too long. So before we get our response, we just want to remind you once again, *3 to get into the queue. We have, once again, with us two representatives of the hospital this evening, Dr. Taslim Nimji, and our first speaker will be Barbara Collins, the CEO, to address that very question of hallway medicine.
Thank you very much for that question, and thank you to everybody who has joined us this evening. It's always gratifying to hear from the community and to understand the issues that are of concern, and certainly hallway healthcare and wait times in emergency departments or coming for tests are one of those. So one of the things I do want to say is that Humber River, as all hospitals in Ontario's emergency department volumes continue to grow. But the most important thing to remember is that in an emergency department, we really want to see the sickest of patients first. And so we have a triaging system, which Dr. Nimji is very aware of, where we grade the patient on how ill they are, and it is our responsibility to look after the sickest of patients first. So that is always something that might make you feel like you're waiting a little bit longer, particularly if a really ill patient comes in. One of the challenges that we are faced with, and particularly over the Christmas period, is increased volume. So we built our emergency department to see around 300 visits a day, and over the Christmas period, we saw somewhere between 450 and over 500 every day. So a lot more patients than we anticipated. We also had about 85 to 100 ambulances a day, and so often those are the sicker patients, and we work to offload the ambulances and get them back out. But in terms of caring for our patients, we always look at how we can improve the flow. And the very purpose of the command center and the information you see behind us is in fact our opportunity for ensuring that patients get in, get seen as quickly as they can. We have a target of seeing the physician within 3 hours of arriving, but also getting the patients to a bed as quickly as they can. And in the period of time that our command center has been open, despite unprecedented number of patients and visits, we actually have eliminated hallway healthcare at this hospital. Our patients may wait a little bit longer in emerge to get a bed than they like, but our average length of time prior to the Christmas period was about 11 and a half hours from the time you get an order to be admitted till you actually get to a bed. In the province, generally, it's around 44 hours in large community hospitals. So we're very proud of that. We've been able to, we don't have patients in places that are not patient rooms. We are not caring for people in hallways. We're getting them into a bed where they can have some privacy and some quality care. And the command center has helped a lot with that. through flow.
It's just a good example of what you'll learn about the hospital over the next hour, but we'd like to learn a little bit about you. Think of, when you're answering these questions, as the number that corresponds on your phone to your answer. For instance, the first question, what age demographic are you in? If you're 18 to 30, press 1. If you're 31 to 49, press 2. 50 to 64, press 3, and if you're 65 plus, please press 4. We'll get back to you with with all of your responses and the percentages. We'll have a few more questions throughout the hour as well. Once again, if you have a question, *3 is the number. Dr. Nimji, the next question for you, what is being done to enhance the level of healthcare at the hospital?
So at Humber, certainly, being a high reliability hospital and patient safety are two key priorities for us. And we certainly leverage our digital platforms to allow us to achieve that goal. And so you can see behind us the command center, and we're going to talk a lot about what value that command center has for us. But I think specifically when we talk about patient safety and ensuring the best outcomes for our patients, I think this is a really great time to talk about the clinical analytics tiles. So here at Humber, part of our phase 2 or generation 2 of our command center is the clinical analytics tiles, which are a world first. And so, I think it's worth pausing for a second. What are we talking about clinical analytics? That's a bit of a mouthful, right? And so analytics are really about taking data, that's information that you're collecting, and trying to understand and find meaning from that data. And you're applying statistics, mathematical algorithms to try to understand and take meaning out of that data. So what we're doing here is looking at the data that we're collecting from our patients in real time at the bedside, from lab values, things like that, and trying to apply clinical analytics and algorithms to that data to then help us reduce harm and improve our patient outcomes. So a great example, or a concrete example of that, would be our mother-baby tile. And so, we often say in healthcare, when something goes well or is simple, we call it unremarkable. And it's funny because having a baby is probably is definitely not unremarkable. It's probably the most remarkable thing. And certainly for my 2 kids, those were the 2 most remarkable moments of my life. But most deliveries they're pretty straightforward, right? They're run of the mill and not a lot happens. But there are those in rare circumstances where there can be inherent risk. And when there is risk, the outcomes can be really catastrophic to mother and to baby. So what we're doing is collecting data at the bedside during this peripartum period. So during the laboring process, during the delivery, and also during the early hours of the child's life, putting that all together and then saying, what can we see so that we can predict, looking forward, risk to the patient, as opposed to what we've always done traditionally is look back in the rear view mirror and say, things didn't go well and why. Now we're able to actually collect this data and look forward and say, looks like things are trending in the wrong direction. There's a potential for things to go badly. Let's preempt that. Let's put in a clinical pathway or an intervention that can help that patient so that we can prevent that outcome. So we're doing that in maternal health. We're doing that also in seniors care, where we're looking at falls risk. We're looking at delirium scores. We're doing that in areas of pain, where we're looking at pain scores and seeing how will that predict outcomes for patients so that we can really get on that early on. And another big area where we're focusing our attention is sepsis. So we're using scores to look at risk of infection. And as an ER doc, how wonderful is it for me to have a patient coming in, registering, and at triage getting information about their vital signs that already are starting to put up flags that this patient is at potential risk. So not knowing that, yes, this patient is septic and has overwhelming infection, but this patient is at risk of that, so that early on we can start to line up our staff and our resources to prevent that bad outcome for that patient.
It's easy for a layperson like myself to come in here and just be blown away by the technology here in the command center. But you brought up a key part, Doctor, and that is the digital world can give us predictors that the analog world never could.
Absolutely. Absolutely.
And that's one of the reasons why we really embarked upon the command center. With our digital information, the generation 1 of our command center was to get the patient flow right, to save hallway healthcare, to end it for us, to actually save some of the resources that are very expensive when patients are in a hospital and don't need to be here. And then the second phase was using the data to really help us provide safer care and to really look at how we can and in advance know that a patient's condition may require an intervention. And the team that works in the command center, who is behind us here, will intervene in a nursing unit. Hospitals are busy places. Staff and physicians get very busy, and we really consider this a bit of a safety net, an opportunity to see what other hospitals we haven't been able to see in advance before, and really help to care for that patient in a new, safer, and unique way.
Thank you to everybody who responded to our first question. What age demographic are you in? 7% 18 to 30, 7% 31 to 49, 35% 50 to 64, and 51% 65 plus. Let's get to our first question here from the web. By the way, if you're on the phone, *3, we'd love to take your call as well. Kimberly has a question. As the baby boomer generation continues to age, and as we look, once again, 51% of those joining us, 65 or over, is the hospital a good place to grow with the changing demands of their future healthcare needs?
So maybe I'll take an opportunity to answer that question. All of us in healthcare look at the pressures in hospitals across Ontario, look at the long-term care pressures, and you can read about it in the newspaper all the time. And so it has to be a multifaceted approach. We can't just build more hospitals. We can't just build more long-term care beds. We have to look at things like the Humber River Hospital Command Center that allows the flow to work better, that allows us to save spare bed days. But we need to look at how to keep the community healthier, how to work collectively on improving the health of the community as all of us age. So we need hospitals, we need long-term care differently. The Ontario Health Teams, which I think we'll speak about a little bit later, is an initiative to bring together the providers to say it doesn't always need to be a hospital. What about virtual care? How cool would it be for you to flip open your telephone and say, I need some advice on whether this fever is anything to worry about, and immediately connect with somebody in a video conferencing system where a physician or a nurse practitioner or a nurse is talking to you about what you're feeling and how you're feeling and whether or not you actually need to come to a hospital. Maybe you just need a prescription, which, boy, we can email that off to the pharmacy for you. Those are the kinds of things we have to look for in the future. We'll definitely need more hospitals, we'll definitely need long-term care beds, but we need to look at a different way of looking after each other, of caring in the community, and of keeping people healthier.
Let's take our first call here on the subject of this hospital, Humber River Hospital and Clinics. Jay Cassiato, good evening.
Hello.
Hello.
Hi.
Hi, you're with us live. Thank you very much for joining us, Humber River Hospital.
Oh, thank you. My name is Josie, and I volunteer at the hospital, the front desk, and I love the way it works. All the clinic is in the front. We have people that are amazed about the hospital. But then I got a little disappointed because I live in the area, I work in the area, and I know people that come to that hospital, and I want them to be happy. That's why I volunteer there. And they're not too happy with the emergency because the emergency is very crowded, not very clean, they say, and they wait a long time. So can be fixed. I don't think it's a huge problem for me that I think, okay, put a little bit more people there to work and the problem will be solved. But maybe it's not. So I need to ask you this question, and I want to know why.
Yeah, sure. Thank you for your question. Thank you for calling in.
You're welcome.
Certainly, and thank you for the opportunity to answer. So you're absolutely right that we can have days where we're extremely crowded in that emerge department because of what we call surge. And so this can happen sometimes in a predictable way, like when we have flu season approaching, we certainly staff up to deal with that. And when we have holidays, we know that our volumes go up, and we staff for that. And like Barb was saying earlier, this Christmas and New Year's period, we had volumes that were unprecedented. We certainly reached our all-time highs of over 500 people per day. So while we do our best to anticipate those volumes, in the emerge, you're always sort of playing this game by looking back at what volumes have been, looking at patterns such as, like I was saying, where you can expect surge like flu seasons and such, and then putting all that together to actually staff appropriately. Now, here at Humber, what's unique is that we have the added value of being able to really leverage the technology of the command center, for example, to try to improve flow in the other areas of the hospital to deal with that surge. So when we have more people coming in, and if we have more people being admitted that require beds, then we try to make sure that we're using our resources best so that we can keep that flow going, so that we can keep making space for the people that are coming in through the emerge to then be seen and treated appropriately. And so certainly that is something that we keep striving to do, and we keep looking at creative ways to do better as these volumes keep increasing. And so staffing is just one example, but looking at creative models. I know Barb talked about in the future when we look at, is virtual care, is there a role for virtual care in the emergency department? We've done things like create a Totally Kids clinic. Right. And so this is where we recognized that we had a lot of pediatric population coming in through the ED, and many of them had coughs, colds, things like that, that didn't necessarily require treatment within the emergency department. And we also didn't want children sitting in the emerge for long periods of time. And we recognize that for families, it can be challenging to get in to see a pediatrician during working hours. So there was a clinic that was developed by the hospital looking at this information to say, let's create an after hours clinic. So 7 days a week from 5:30 to 8:30, the patients can be seen in the Totally Kids clinic. And if there's something that's identified there by the pediatrician or the pediatric nurses that requires emergency department resources, then that patient is then sent to the emerge. But otherwise, that patient can be seen more quickly and streamlined through that. And so certainly we take that feedback, and we're constantly trying to do a better job of making sure. And again, it is our sickest patients that get seen first, and it always comes down to that. And so, sometimes you have to wait a little bit longer, and longer than you would like, and longer than we would like to have you wait. But if somebody comes in the door that is really sick, all of our resources get diverted in that direction first to ensure that patient is safe before they get redirected to the other patients.
Understandable. Thank you, Doctor. A very timely question from Lisa about something that is in the news and on the minds of a lot of Ontarians, Torontonians today. Good evening, Lisa.
Hello there.
Hello. Thank you for joining.
It's Lisa speaking. With the coronavirus that has hit China and has spread to several countries, I do work in crisis management response for the province, and I am just curious, now that we know that there is a case reported in the United States, how well positioned is the hospital to deal now with potential respiratory illnesses, and are you prepared and ready now for, it is the Lunar New Year for the Chinese, and there's going to be a lot of folks traveling and potentially coming to Toronto. Are we well positioned to deal with it?
Thank you very much for your call, Lisa. We appreciate it.
Lisa, it's Barb Collins, and let me just give you a bit of information about Humber and a little bit of what we're doing. First of all, we always remain prepared, and we always do screening where there are viruses anywhere in the world. Many of us lived through SARS, as probably you did too if you're at the ministry, and so Toronto is probably more prepared than many cities in the world, having had that experience. And certainly we started talking 2 weeks ago about getting ready and do we see anything that we need to prepare, and we have prepared, as I know the province has. You began to see screening going on at airports, and this kind of activity will ramp up. When we built Humber River Hospital, we built it very differently than other institutions. First of all, we are 85% single patient rooms. So you're not sharing a room, you're not sharing a bathroom with anybody else, which is a great protection. The other thing we did is we learned from SARS, and when we designed this facility, we're able to isolate particular units, put them into total isolation, negative pressure, so we have somewhere to care for these patients properly, not only in the emergency department, which is largely single patient rooms, but in all of our patient care areas. And finally, the other thing we did when we designed Humber River is we created it such that our outpatient areas and our operating rooms can be totally separated from the inpatient areas. So you may remember in the past with things like SARS, you couldn't do surgeries and some of the things you wanted to do. We won't have that problem this time at Humber because we're able to separate those areas. And finally, I will add that we built the building with 100% fresh air circulating. So there is no recirculated air at Humber, which of course is also a healthier environment. So I believe that our building is prepared, I believe we're prepared to monitor it, and I know that the province has already begun a strategy to deal with this kind of thing, something we should be ready for all of the time. And I might remind people that if you do feel unwell and you need to come to the Emerge, do come. But if you're coming to visit a patient and you've got a respiratory illness, don't visit. Try to visit at another time when you're not sick. And for everybody, wash your hands all of the time. That is the best thing you can do.
For everybody who is just joining us, thank you very much. I'm here with Dr. Tasleem Nimji with Humber River Hospital and Barbara Collins, the CEO of the hospital. Let's go to our second question here. We'd just like to know a little bit about what you think. And here is the second one. How would you like to hear from the hospital? On your phone, the corresponding number to each one of these answers: 1 for the HRH website, 2 flyers or ads in local newspapers, 3, the hospital's social media channels, 4, direct mail to your home, 5, an email newsletter, 6, television or radio ads. I'm going to punch 6. And number 7, posters or electronic displays while visiting the hospital. On your phone, you can answer those with the number corresponding to your answer. Also on your phone, if you have a question, you can join the lineup by simply dialing *3. Let's go to another question off the website, and that is about the hallway medicine and the continued work on that. Is there, and this question comes from Neil, is there an actual noticeable, definable improvement in patient health care as hallway medicine is eliminated?
You want to start with that?
I do. At Humber River Hospital, by eliminating hallway medicine, we actually have the patient now in their single patient room. They have all of the resources that they require there. The staff assignments can be properly adjusted to care for the number of patients they should. Our patient rooms are very digital. The equipment in that room is linked to the command center. So for us, it's very important that we not be caring for patients in hallways, in auditoriums, and in classrooms. And so we do certainly believe that a patient in a proper bed, having all of the resources that they require, is the right way to care for patients. And that's why it was so important to us to get to that state.
And again, being all digital would give you the opportunity over a week or a month or a year to look at hard numbers to see the improvements that are, or I guess aren't, being made, right? Very easy to tell.
It does allow you to do that.
Dr. Nimji, I'd like to ask you a little bit about specialists and their role in the hospital and access to specialists here at Humber River Hospital.
Yeah, sure. So we're a large community hospital, so we have many subspecialty areas within the hospital. And just off the top of my head, we have lots of surgical specialties, including orthopedics. We have bariatric surgery, urology, vascular surgery. We have lots of inpatient services, including nephrology, general medicine, neurology, just to name a few. And then from our outpatient clinics, we certainly have a lot there as well. And so we have, actually, it would be a good point to maybe pause and talk about mental health. We have a large inpatient as well as outpatient mental health service. And that includes both the adult population as well as the pediatric population and adolescent youth population. And we're certainly seeing an increase in demand from that sector requiring services for mental health. And so we're really grateful that we can rely on these services. As an Emerge doc, certainly knowing that I can see an adolescent person coming into the Emerge with new depression or anxiety, and knowing that I can lean on our inpatient services, but also on outpatient clinics that are tailored towards adolescent mental health is really quite fantastic to help close that loop. We also have a bariatric clinic as well, which is really sort of focused on multidisciplinary approaches to this patient population and ensuring that they provide care in a non-judgmental way for these patients that we're quite proud of. And then we have a very large cancer care clinic that treats our patients that are living with cancer. And those are just to name a few. And in terms of getting into these clinics and being able to see the right subspecialist, there's many ways to do that. So certainly your family doctor can refer you to the appropriate service that's required. If you come in through the emergency department and it's determined that you need to see, say, an orthopedic surgeon, or it's determined that you need to see a nephrologist, we will do that referral for you within the emergency department and help set up your appointments. And then there are central services that your family doctor can also tap into and that are available on our website to get referrals.
Let's go to another question, and I think as we talk about the hospital itself, this one comes from Ashraf. Good evening. My question is, are you interested in mobile diagnostic imaging such as digital mammography or digital portable x-rays so you can cover a wider geographic area rather than have patients come to the hospital? Is that a possibility?
Yeah.
So we absolutely believe it is a possibility. People will always need hospitals, but as I said before, it can't be the only thing. And so you need to look at where people can get testing and get testing fairly quickly. In fact, one of the reasons sometimes people come to the emergency department is hoping to get their diagnostic imaging quickly. And so we are interested in all of those kinds of technologies. At Humber River, we're interested in decreasing the wait time people have for testing. And for that reason, just to give you an example, some of the funding that we were able to save from our process flow and not having hallway medicine, we were able to purchase our own MRI machine, an additional third one, and we staffed that with our own savings as opposed to relying on the Ministry of Health to do that, so that we have an opportunity to test our patients sooner. So I think it's a combination of being very efficient in the hospital. It's a combination of external resources. And we look at both of those as an opportunity to get patients their testing quicker and sometimes somewhere other than just the hospital.
Dr. Nimji, let me ask you this. How often do you hear from somebody as you're going through a list of their symptoms? Well, I Googled.
Often.
Yeah, I bet.
Often.
I bet.
And you know what? I think there was one point where the approach was, oh no, like why did you do that? And I think that's really changed, because the reality is that more knowledge and more access to information is not necessarily a bad thing. So if your patients are Googling their symptoms first, that's great. You want to just ensure that you educate that patient to help push them towards evidence-based resources online so that they can go ahead and look up their symptoms and try to self-diagnose, but again, using the appropriate resources so that they're getting proper information that is evidence-based and accurate.
We're going to come back and find it.
I was just going to add,
no,
one
go
thing,
ahead.
sorry. Being digital, we actually have an integrated bedside terminal we call in the patient room. And so we're able to actually, based on what the patient's diagnosis is or their health problem, not only access their record there, providing TV and providing video and providing internet, but we also have educational videos that we can push to the patient that they can look at about their condition. And the other thing I should say is that we do have a health record at Humber where you're a patient. You can sign on and you can receive your diagnostic imaging tests, your laboratory work, and within the next few months you'll be able to see your discharge summary. You can certainly see a lot of your laboratory tests, appointments, and I would encourage anybody who comes to Humber River to sign up for your chart so that you too can be part of looking at your healthcare information and part of helping with your healthcare.
All right, well, why don't we go back to another call here. This one is from Phil. Good evening, Phil, and welcome. Thank you for joining us. Oh, just can't seem to get that. There.
Thanks for hosting this.
No, my pleasure, Phil.
Yeah, it's good to hear your voice on something beyond Q107.
We think so too.
Thank you, Phil. What is your
you are welcome. Well, you've actually just answered the question that I had. I'm interested in access to patient health and patient health information, and you've all just brilliantly provided the response to it. Being in a hospital is really scary. And having the kinds of information that helps to make the situation a little bit easier is always good. And it sounds like what's happening at Humber River is cutting edge.
Thank you for
that,
Phil.
I tell you, Phil, I walked in here tonight and I can't believe not only the way this command center looks, because it truly does look space age, but what it does is really the impressive part of it, and how the information that is gathered here can not only provide comfort and health, but truly save lives. Phil, thank you so much for your call. So the answer to our last question, it seems like the email newsletter is very popular. I think
that's good.
A lot of people.
That is very good to know.
30% say email newsletter, 29% television or radio ads, and then all under 10% for all the other options on how you would like to hear from us. Of course, the website is one of the places that you may be seeing this evening. the only place you would actually be seeing it, but on the phone, *3 if you have a question for us. Let's ask you another question, though. Based on what you know about Humber River Hospital and what you've learned so far tonight, is the hospital focused on the right things? Hit 1 for yes, 2 for no, and 3 for I'm just not sure. Virtual care, we're going to talk about that in a moment from the standpoint of those who live in the area and whether or not that would be palatable to them. Has the world of virtual care gotten to a point where it is a viable alternative to coming to the hospital?
So, when you look at the data around virtual care, majority of the virtual care pilots that have really taken off have either been where you're trying to bridge a distance gap, right? And so this is where the patient will sometimes come into a host site, and there may be a nurse, for example, that's present. There may be some technology, vital signs ability to gather information from the patient, and then that's fed to a physician that's not at that site, and that's one form of virtual care. And then there's the other, which is just direct. So that's point to point, where the patient is calling in and directly speaking to their physician. And this is what you're seeing really grow. And this is almost like, you think about like a WhatsApp video call or a FaceTime video call with your care provider. And we've certainly seen this really take off in the area of mental health and in the area of psychiatry, where you're seeing a lot of virtual visits for mental health being accessed. So you can be traveling globally and still have regular access to your mental health care provider, not have to miss appointments because you're tapping into a virtual care network to do that. And now we're starting to see people looking more and more at the role of virtual care beyond and outside of mental health. So you're seeing virtual care being used in emergency departments. You're seeing virtual care being used in inpatient settings where you might have not enough care providers. We're seeing that, for example, in the Maritimes right now, where doctors are virtually able to do rounds on patients in an inpatient setting. And so certainly, like I said, in that case, again, you're looking at where there's resource limitations, but now you're looking at urban settings where there's a lot of density and a lot of need from patients, and maybe these aren't what we consider resource poor, resource deplete areas, but saying how can we get creative about providing care so that not everybody's having to come into a hospital or wait in line for a clinic appointment to access their care virtually. And you're seeing that really open up from physicians in terms of wanting to get involved in that.
We live in Canada's biggest city, and all indications are the city will continue to get bigger, not only from those who are coming from other places in Canada, but from those who are coming from different parts of the world as well. And Mary has a question on that subject. Good evening and welcome, Mary.
Yes, good evening. Very nice to speak to you. Thank you.
You as well.
Thank you. My question is, I keep reading in the paper every year the immigration numbers are going up in Toronto, and over the last couple of years, the numbers that I'm reading are 100,000 immigrants into Toronto alone. I don't know if these numbers are correct because I'm just reading it from the paper, but I just wonder what the impact is on doctors and hospitals with these numbers, and how do they integrate these numbers every year? And the second part is, does the government do anything in monetary means to accommodate all this influx of immigration to your end, to the hospitals?
So first of all, I'll say as a hospital administrator, I think we watch all of these things. It's population density that requires you to have busier emergency departments and busier hospitals. And I don't know that it's just immigration. There's also a move of people back into the city from the rural areas. So there's lots of reason why the population is growing. The Ministry of Health has a number of methodologies for how they fund hospitals. There's global funding. There is funding for particular special programs. There's funding for lots of different ways for how ill the patients you're caring for, what kind of teaching you do, all of those methodologies. All of us in hospitals would say, and the ministry will laugh, it's never enough money, but it is a significant portion of the tax dollar that goes to healthcare. And so that's why, while we are getting busier in Toronto, while it's larger,
whether it's immigration or people moving in or the aging population, we need to figure out how to deliver care differently so that it's affordable to all of us.
And it's funny when you say that, when you think of our society and how many things that we may or may not share. For instance, public transit. You may take public transit, you may not.
Right.
This is the one thing that we all share as a province and as a country.
Yeah.
Yes, and we know that the aging population is another large group. I mean, people are living for a longer period of time, and many of them are living healthier, and that's great. But that's another pressure we will see. We're already seeing that now with long-term care needs and with home care needs. And again, that's why we encourage digital health care. We encourage the kind of systems we have here. We encourage an opportunity to look at delivering care differently and not always in a hospital.
Well, it's a good thing it's not like 700 or 800 years ago where 21 was the life
Yes, exactly.
expectancy.
We're all happy that we live longer.
For sure.
We do need to look after our health.
Okay, first of all, I've got good news for you. The last question, based on what you know about Humber River Hospital and what you've learned tonight, are we focused on the right thing? 73% of our respondents said yes.
That's great.
Excellent.
Only
fantastic.
6%
Nice.
said no, and 21% said not sure, but we'll let
Keep
you
listening.
know. Let you know next time out. So our
right.
next question, and that goes back to a question the doctor answered a few moments ago. Virtual healthcare, providing an opportunity for you to see a doctor or a specialist online from your home. Is this a service? If it were offered, would you use it? 1 is the number to hit if you say yes, no, number 2, and hit number 3 if you're not sure. Virtual healthcare. You're getting a diagnosis or an update over the phone rather than in person. If you think that's something you would be interested in, 1 yes, 2 no, 3 is not sure. Let's take another call here, and this one comes from Deborah. Deborah, I think, wants to talk a little bit about what goes on in the nighttime. Hello, Deborah. Hello, Deborah. This happens to me at work all the time. We'll just move on. Okay, I'll get you to answer this one. Have the healthcare cuts affected the hospital, and what is the hospital doing to try to get the government to reinstate the cuts that have been made? So I guess the first question, have there been cuts, and how do you deal with it?
So at Humber River Hospital, we have not had cuts at this time. We actually are in a growth time where we are having more and more activity. One of the things that we consciously began to focus on when we moved to the new site was efficiency and the opportunity to save resources and turn those dollars back into healthcare. And I will tell you that I think many hospitals are working on this. We recognize the opportunity of having moved to a new hospital and having had the opportunity to implement the digital. But I will tell you that for Humber River, this saved $11.5 million with some of the digital technology we put in place by freeing up beds and allowing ourselves to be more efficient using the predictive analytics, using the command center, and that's money that we've turned right back into frontline care. We are adding registered nurses on day shift and on night shift because we recognize our patients are sicker. A number of initiatives we've been able to implement as a result of being efficient.
Let's take a call from Kimberly. Hello, Kimberly.
Hello, how are you?
Very well, thank you. Do you have a question?
I do. As a frequent user of the hospital, I've really noticed over the last time I've gone to other hospitals that the employee engagement and the professionalism is really off the charts in New Humber Hospital. You know, I've been in the plastics clinics, the women's breast health, and the customer experience is just extraordinary. So my question really is, was there a program put in place to bring the staff on board, or is this professionalism something that's just really grown organically with the pride of being such a great part of the community?
So you
And
warm my
yes,
heart
that's
telling
right.
me that. I have to say that to you. You know, when we moved into the new hospital, I think we kind of thought a beautiful new building would do it. Well, guess what? It's all about communicating and talking with the patients and the families and understanding that people come here because they need our help and we need our help and we need to communicate with them. And it is something that our team, our staff, are all committed to. We have done some training. We have worked with a group called the Studer Group that has helped us to really focus on. We engage the staff and physicians. We give them the tools to do the job. We make sure that things are clean and neat and efficient for them, and everybody then has enough time to communicate with the patient, the family, and provide care. And it is something we work on every day. We talk all the time with staff and physicians about it. Our managers and our directors round with patients. Our resource nurses talk to patients each day, and we talk to people in the clinic. So it is something we are committed to, and we always work on at Humber, and I'm happy to see that you've noticed that. Thank you.
You can simply hit *3 on your phone if you'd like to ask a question. Actually, a number on this question, Anastasia and Sharif among them. What about different languages, interpreters? You come into the hospital and you have little or no knowledge or ability to speak English. How do you deal with the staff here?
It's a great question, because it is such a reality for so many patients. And I think a previous caller talked about how when you're unwell, it can be really scary. So now when you're accessing healthcare services, either in an emergency department setting or outside, this is usually a point at which you're feeling vulnerable. So to have a language barrier really adds to that. And we are so fortunate to have services that we can rely on. And so in the past, that meant calling in a line, like a language line we used to call it, to speak to an interpreter. And that's really changed and grown over time. So now we actually have, speaking of virtual care apps, we even have what looks really like, again, like a video conference call with an interpreter. And it just comes on a tablet device, and you can be speaking with the patient beside you and this third party. They give consent to do that and have this third party then part of that visit with you, with the patient, providing real-time interpretation in that moment in a multitude of languages. So I see patients in the ED frequently that have a language barrier, and never have I had a language that I was not able to find an interpreter that could help me with.
Wow.
And you mentioned Google, so I'm gonna bring it out. You know, sometimes there's a computer in every single patient room here at Humber, and so sometimes it's so simple. You just turn to the computer screen and you go to Google Translate, and you and the patient beside you are typing away and having a conversation back and forth, and it's right there, and you're able to create. And it means so much to patient-physician rapport when immediately you get rid of that barrier and you can have a conversation and understand what the patient is worried about and what's brought them there, and then reassure them that you're going to do everything you can to help them. It's really quite remarkable.
Do you mind if I ask a question?
Yeah.
Go ahead.
So I would guess there are backup generators for a hospital. There have to be, but we do have power outages from time to time. I can only imagine the breadth of the internet capabilities here. Does everything work very quickly after a power outage? What happens when there's, say, a citywide or a province-wide power outage?
So understanding that we were going to be digital and knowing that you can't go down when you're this digital, we actually had a number of things that we built into the building. We have triple redundancy in our energy. We have 5 generators. We can have the city, we have 2 sources of city power coming in. So we lose one, we have the other. Should we lose both of them, we have a generator system that kicks in, and within a varying amount of time, elevators first and critical equipment first, everything comes back up within about 5 or 6 minutes on the generator. Should that generator fail, we have another generator. Should that generator fail, guess what? We still have a third one. So we've done what we call triple redundancy in energy in the building. And then our building operator and our IT team, who are wonderful, work with us. We require our building to have what we call 5 nines uptime, less than 5 minutes of computer downtime in the course of a year.
Wow.
So we designed the building with that in mind, and it was a really great opportunity to do that.
And they would know this is a leap year, right?
They would know,
It's gonna
yes,
be one more
we're
day.
fine. We're just fine with the leap year.
Neil has a question. Do nurses at Humber River Hospital report a better work environment since the positive changes in flow?
They do report a more comfortable work environment and better patient care. So we're seeing that in a number of ways. We did produce a number of journal articles last year, which are available online on our website, of actual research done with our nurses. Do you feel that you can adapt to the digital equipment? Do you feel that it is improving your care? Do you have more time to work with your patients? And there was a lot of positive information from staff out of that. They felt that it was a safer environment to work in, They told us that it was easier to provide care. They carry a telephone with them, and when the patient calls the call bell, they don't have to go to the nursing station and answer it. They can directly connect with the patient and find out what they want. So in terms of the distance and the time of walking around, much better. In terms of communicating with their patients and each other, much faster and much safer. And many of our digital systems have made it easier to work. A computer in the room that allows them to look up the patient's information, all of those kinds of things have made it better. And what we are seeing in terms of our patient satisfaction, and that tells us that our care is better, is that 89% of the patients who have been surveyed from Humber River tell us that they would recommend this hospital to their patient, family, and friends. And so that's a very high level of satisfaction.
Let's take another call here, and this one is going to be from Maria. I think more of a comment than a question, but nevertheless, Maria, welcome, and say hello to Dr. Nimji and to Ms. Collins, the CEO of AHRH. We can hear you. Hello. Maybe we got popped.
Hello.
There you go. Hello,
Hi,
Maria.
Hello. I don't really have a question. For me, it's more. My husband is a regular patient at the hospital due to that he has he's been exposed to asbestos, so he only has 17% of half of his lung. So when he gets sick, in 2017, he went into the hospital and he died for 8 minutes. He was brought back at Emerge. Then we spent 3.5 months at ICU. Mm-hmm. And everybody was super helpful and nice and supportive, and that's one of the things that the staff, if it wasn't for some of the nurses, he wouldn't have made it, nor would I. From the outcome of that, he now suffers from extreme PTSD. Mm-hmm. So for me, bringing him in, he makes me promise that I would not leave him there. I would not put him into the hospital. Like, he'll go in to have an x-ray done to just make sure that if he has a pneumonia or what's happening. So in 2019, he had a pneumonia. He went in. We went to Emerge. And they, again, because he only has 17% of one of his lungs, they wanted to put him into the hospital. And I tried to say, like, I can't put him in because I promised that he would come in, but I'd take him home. So sometimes the service is super good, super helpful, super supportive, but sometimes it would have been nice to have been heard that we didn't want to stay in the hospital. I just need him to be checked out and an x-ray. He had a pneumonia. He needed to be medicated and sent home. Lucky me is that one of the doctors that was his doctor in 2017 at ICU, Dr. Laura Good, happened to come down to Emerge. And when I saw her, I told her what was happening. So she was very kind, and she actually medicated him and actually sent him home that day. The hospital is marvelous. I have nothing bad to say about the hospital. If you go back and check in 2018, they actually asked him to take some pictures and put them up at ICU because apparently he was the first patient that died for 8 minutes but walked out of ICU 3.5 months later. So it's like positive. Services, it's positive. But the fact that they made me wait for 48 hours at Emerge because I could not leave him there. Mm-hmm. And if it wasn't for Dr. Good, they wouldn't let him come home. Mm-hmm. So sometimes there's exceptional circumstances. Yeah. And I think that in that sense, it would have been really helpful to have somebody listen and support me on the decision that I wasn't trying to bring him home because I didn't like the hospital, but it's because of the aftermath of what he went through that the request was made.
Well, Maria, thank you very much for that. And I think.
But like I said, services are amazing, and I mean, like we are like 2.5 miles from the hospital, and we won't move because of the hospital.
Thank
Does
you
that
so
say
much.
anything?
Maria,
Well, that certainly does say something right there. Maria, thank you very much. I think it's worth readdressing the hallway and why your wait in emergency may be a little longer, because I think your explanation earlier in the hour does make a lot of sense as to why have a transit point along the way. Why not wait until that bed is available?
And to that last caller, thank you so much for sharing your personal story, because that's not easy and that takes courage. And we're always looking for your feedback. And so while we're certainly proud of the things we do well, nobody's perfect. And we always want to know from you what your experience has been like. And we learn from that. As physicians at the bedside, sometimes maybe we are really excited to provide a certain treatment, but for a multitude of other reasons that you can't find in a medical textbook like you just described, it might not be the right decision for you or your family. And you want to be able to express that and share that with us. So, and that's important that we have that dialogue. So that feedback is very well taken. Thank you for that. Thank you.
Maria, it's Barb. I might ask you to call the hospital and speak to our patient representative at extension 82256, 82256. We can put a note on your husband's chart that kind of explains this up front. We have a way of flagging charts for this kind of a thing. And another time when you come in, it'll be known up front, and that might make it more comfortable for you as well.
Here's a question. This comes from Jesse, and this on the website. Do you currently have aphasia-friendly communication available in your IBTs?
That's a good question. And so I don't know the answer offhand. I have to be honest. I'd have to look at whether that's particular services available. I know we have a whole host of services that are available to people that have varying degrees of deficits, and aphasia is one of them. But I'd have to get the answer to that question specifically. And if you want to get us your information, which we can do offline, we'll absolutely get back to you to give you an answer to that question.
Okay, let's take a listen to your responses to our fourth and final question. Virtual care provides an opportunity to see your doctor specialist virtually or online from your home. If this service were offered, would you use it? And 60% said yes, 14% said no, and 26% said not sure. Would it be more effective in follow-ups? Would an in-person start, and then the follow-ups, the doctor now knowing what's going on, the follow-ups don't require coming to the hospital?
You're certainly right. Like, you're exactly right by saying in which setting is virtual care appropriate, because it is not in every setting that virtual care is appropriate. So it's really about finding the right set of case examples, and that's how these pilot studies usually start. So even as we start exploring virtual care and looking at our journey down this pathway, it's identifying the right set of patients with the right clinical circumstances where we know that there's no threat to the safety of that patient if we try to treat them virtually. So in some cases, it might be that the initial visits are done in person and then follow-ups are subsequently done in a virtual manner, unless there's some change that occurs to the patient that will necessitate that patient coming in. But it also may be about setting apart which diagnoses lend themselves better to care in a virtual setting and looking at that, and then deciding which patient populations that are first willing and ready to try this with us in that journey to start doing this with.
The other part that I would add to that is another phase of our command center. Generation 3 of our command center not only allows for the virtual care, but it actually allows us to monitor patients in their home setting. So right now we have patients who we monitor for nocturnal dialysis. But what about a patient like Maria's husband? What if we could monitor him in the home, and although he's got a pneumonia and not well, he has technology, wearable technology, where we here in the command center can see what's happening with him, if his blood levels are deteriorating, if his oxygen is deteriorating. John, I showed you how we can do that with admitted patients. There is technology out there where you can do that with people in their home, and that is a future phase for us here at Humber River. That's our phase 3, generation 3 of our command center that we're beginning to work on now.
I saw a couple of years ago some really startling statistics about the abuse that admitted nurses can take from at some times, and it sounds like in some cases all the time. And I recall many years ago going into a hospital and seeing the admitting nurse behind plexiglass, and I thought, wow, there's something wrong about that. Tell us a little bit about the security at the hospital and the necessity for this to be a safe place not only for those who work here, but for those with physical ailments, and very much so for those who are having mental issues.
So certainly we take security as something that's of paramount importance for us, and that's security and safety of our patients and security and safety of our staff, both. And so you're right, that image that you described with that plexiglass, but it's important to create a culture of safety so that you don't need that plexiglass, so that you can come out from behind that and have proper, real communication with your patients. So in the past, when you picture that room with that nurse having to be behind that plexiglass, you picture patients that are irate and angry, but usually for very real and valid reasons. They've been waiting for a really long time. They feel like their call bell has been rung 5 times and it's not been answered. You know, they feel like they're in pain and they're not getting the medications that they need. But leveraging all this technology that we've talked about is so that we can decrease all of those settings, right? It's so that patients aren't waiting without their pain medication and in pain for long periods of time, so that a patient doesn't have to ring a call bell and wait for somebody to go to a nursing station to hear that call bell, so that it comes directly. So when you're able to do all of those things, patients are getting the care that they need quicker, which is why they came to the hospital, so that people don't have to, people that are feeling vulnerable and scared, those are the people that are usually louder because they're trying to advocate for themselves. And when you create a setting where they're being heard, you just see that things don't boil over as much. And so certainly we have security to keep our patients safe and to keep us safe, but that culture that previous caller was talking about and that Barb was saying, it sort of warms her heart and mind to hear that. I think that really helps us to then have an environment in which we don't need to rely on that backdrop or that safety drop as much. And we do have, like, our staff carry badges that allow us to actually, there's a button you press, it's an RFID badge, and if you press it, if you're in a situation where you need security, you can call on that security to come. And again, the role of security is to de-escalate that situation for the staff, for the patient, so that everybody is safe.
Well, we are about to, would you like to add to that,
No, I
Barb?
think that's exactly
Okay.
it.
Well, we're about to wrap things up. First of all, thank you very much for viewing, for listening, for asking questions. If you'd like to leave a comment, or if you didn't have a chance to have your question answered tonight, you can email us your question to communications@hrh.ca or call 416-242-1000, extension 82256. To speak to our Patient Relations Department. You can also get up-to-date information by visiting our website at hrh.ca. And I think we did find that the email newsletter, very
Great to
popular
know.
way for people to find out, and radio and TV ads.
Always.
There you
I had to
go.
throw
It's a
that
very
one.
digital world, but that's his PCI.
Radio is far more
Radio's
economical
far
than
more
TV, by the way. So this has been certainly for me and hopefully for you a very informative hour as we, the lay people, have an opportunity to speak to 2 professionals, Dr. Taslim Nimji, ER doctor and Director of Medical Innovation here at the hospital, and Barb Collins, President and CEO of Humber River Hospital. Ladies, thank you so much.
Thank you.
Thank you.
It was a real pleasure.
Thank you, and thank you for everybody from the community who joined us. We really enjoy having an opportunity to talk with you.
Thank you.